To let folks in, I will go ahead and start. So welcome to the 5th session of the webinar series on genetic services in Appalachia. We ask that you mute your microphone for the talk and place any comments or questions in the chat box until the end of the session, and then there will be opportunities to ask questions then. We're happy that you're joining us. We ask that you not record our session. We will be recording this session this time, and we will provide a transcript on our website. We had a little technical issue on our last one, and so we are working to get that added to our website soon. So be looking for that, and we'd be happy to have any comments or questions about that too. And we have an evaluation for that session that we will be sharing so that we can get more feedback. So we will ask for feedback at the end of this session as well. And so we hope to post that in the Q&A. We appreciate your feedback, whatever it might be, because this gives information to our funders about your thoughts, and also as we try to construct a research agenda. As you know, our aims include to develop a research agenda. So we appreciate you joining us. If you wouldn't mind muting your phone or your Zoom, then we will proceed. So each month we're having speakers working in a variety of genetic service provision to medically underserved population with a focus on rural Appalachia. And so now I would like to introduce our speaker, Dr. Rebecca Cronk. Dr. Cronk is the Associate Dean of Academic Affairs at Duquesne University School of Nursing in Pittsburgh. She is a pediatric nurse practitioner and has her PhD in developmental psychology. Her clinical career has focused on children with a range of developmental and genetic conditions. She helped establish the Fragile X Center at Children's Hospital of Pittsburgh at UPMC. This achievement affected interprofessional practice and education in the Children's Hospital in Pittsburgh, and this interdisciplinary center is internationally recognized as part of the Fragile X International Clinic Consortium. Dr. Cronk has served as the president of the International Society of Nurses in Genetics from 2020 to 2021, so she is just finishing her work there, but she continues to be active in that group. She was recently awarded an R25 grant from the National Human Genome Research Institute of the National Institutes of Health to improve nurses' literacy in genetics and genomics to benefit their research, clinical practice, and teaching in order to improve patient healthcare outcomes, particularly those from underrepresented communities. And so I was sharing with Dr. Cronk that her perspective is a much needed addition to our webinar, and I am excited to learn more about the field of nursing genetics and what Dr. Cronk has been working on in particular. So I'll turn it over to Dr. Cronk now. Thank you.
Thanks, Kim. That was a nice introduction. I just want to make sure, does everybody see the full slide, not the split slide? You see the full slide? Okay, that's great. So I'm grateful to be here, and I'm grateful to be able to share, collective knowledge and experiences with one another. I've been able to attend a couple other of these noontime sessions, and I've really benefited from them all. So I hope that today's presentation also benefits you. And I always like a conversational style, so anytime anyone wants to interrupt me, I'm happy to respond. So today I've divided up the presentation into two parts. And so the very first part, I really want to concentrate on the role of nurses in genetics and explore the competencies for the registered and the advanced practice nurse, and also to examine the varied state of genetic and genomic nursing education programs. and also to introduce you to some professional organizations and learning opportunities that continue to promote genetic and genomic development in the nursing profession. And then secondly, which is my second passion, I really want to talk about the intersection of nursing, genomics, and disability. I want to discuss health disparities of people with disabilities, particularly in relationship to genetic conditions, and explore this disability belt of complex diseases that occurs in Appalachia, and it results in these multiplex phenotypes. And then lastly, to not only discuss, I think, the nurse's role, but the interdisciplinary role of health outcomes of people with disabilities as it relates to genomic conditions. So it sounds like a lot, but we'll get there. I wanted to start with this quotation by Connors and Shorn, and it was actually an editorial in the Journal of Professional Nursing. And I'll read it to you because I think it's really important. It states that nurses must be prepared in the fundamental genetic and genomic content to meet population health needs, to understand the molecular and genetic basis of disease treatment modalities, and the recognition of therapeutic response is an imperative for quality nursing care. It is crucial that nurses receive extensive formal and ongoing continued education in genetics and genomics. And so I think this really lays the groundwork of the basis of all the efforts that we're trying to make in this profession to include genetic and genomic content to improve health outcomes for the people that we serve. So I wanted to kind of review where this all originated. So the inclusion of genetic competencies in undergrad nursing has been recommended since around 2006. There was a consensus panel formed by the American Nurses Association, and I want to say roughly 30 other institutions of learning or of other nursing organizations came together, and they published this Essentials of Genetic and Genomic Nursing, and it was a list of competencies. And then in 2008, it was revised, and they added some specific outcome indicators, which I think were really helpful in the fact that it gave, especially nurse educators, the opportunity to think about what these competencies would look like in practice. And then in 2011, this very similar group, including the American Nurses Association, came together and wrote the essential genetic and genomic competencies for the graduate nurse. And both of these publications stem from the first publication, which I have over there, the Genetics and Genomics Nurse Scope and Standard of Practice. That very first publication came out around 2006, 2007, and it was a joint effort between the American Nurses Association and the International Society of Nurses in Genetics. And we developed a scope and standard of practice for the genetic and genomic nurse. This was updated in 2007, and we are actually working on another update beginning right now in 2022, because things have changed so rapidly. What I really find important about all these publications is that the overarching goal has been to make genetics more mainstream and approachable, for all nurses in practice. We don't want nurses to think or be limited that, genetics is just connected to rare disorders. And it's a special realm, but that there's knowledge of genetics and genomics is necessary in routine care across any setting. And that it involves this personal relationship between a client and a nurse. And that recipients of genetic nursing practice can be individuals, families, or communities, or entire populations. And we can, involve or treat people at any stage of life, whether they're pre-symptomatic or at risk, whether we've determined that they are susceptible to a specific disease, or that they just need genetic information and education and help with genetic literacy. So just briefly, some of the essentials of the genetic and genomic nurse, and this is the RN, the pre-license, the basic licensure for nursing. They've divided these components up into professional responsibilities and professional practice. And I've just highlighted the subdomains under each one of these competencies. And these competencies reflect the minimal amount of genetic and genomic knowledge and skills that's expected by every nurse. And these publications on the genetic and genomic competencies, like I said earlier, are also helpful to guide, nurse education and implementation of learning experiences to help the next generation of nurses in the workforce. I have to say, from experience, I started a standalone genetics course here at Duquesne University in 2014. And it was for the undergrad nurses. And initially, and I think this happens even to this day, the nurses, the students, they sort of think, why do I need another genetics course? I've had biology, I've had pathophysiology. Sometimes even the second degree students who have had, degrees in biology previous to coming to nursing school would say, why do I need this course? Why is it important? But I have to say, I based the course here at Duquesne on these competencies. And so it really helps them, bridge that theory to practice gap, right? Like I can learn about inheritance or how to do, a history or perform a 3 generation chart. But what does that mean as a nurse and caring for an individual? So because of these competencies, we do a lot of reflections, we do a lot of case studies, and we demonstrate like why genetics and the nurse make a difference. And I hope that helps you see, and honestly, I have them do impressions at the beginning of the course, and you hear a lot of this negativity. At the end of the course, I will hear things like, this has changed my practice. This has really changed my life. Even personally, they haven't thought about some of the ways that genetics can be incorporated, into, ethical situations, religious situations, thinking about the health literacy of their patient. They can do referral activities by the end of this course, things that they wouldn't normally get in a biology or pathophysiology course. So I think that makes a pretty profound difference, and they see that by the end. And then I also am just providing some, again, domains of the genetic and genomic competencies for the nurse with the graduate degree. And of course, these build on those core RN competencies that are for the undergraduate. But we know that those nurses with graduate and doctoral degrees interface more with treatment and translation of genetic and genomic advances in clinical care, and are increasingly asked to provide leadership in practices and in education and research. So that we know that, advanced practice nurses, they have a more broader scope of practice with more advanced training. So myself as a pediatric nurse practitioner, the Fragile X clinic, is able to, do everything that, my colleagues did who were also from the medical profession, is able to interview and diagnose and order treatments and interpret test results and offer some counseling and referrals. So those are the competencies for the graduate nurse. So let me just say that, there have been many challenges, though, to adapting a uniform approach to genetics and genomics in the nurse and to prepare nurses in their in academia. Many schools of nursing, some of the barriers have been that, faculty don't feel qualified to teach genetics and genomics. And I can totally understand that, right? A lot of times nursing curricula and many of you in pharmacy and other healthcare disciplines know that the curriculum is already packed with a lot of content. So, how do we put in a standalone course? So some undergraduate programs or graduate programs will thread the information throughout courses. So you just get a smattering of genetics and genomics. And then there are some postdoc and graduate programs that receive some T32 grants to advance the training of nurses in genomics. I gave an example here of the University of Pittsburgh, and then the University of Washington has a T32 in the Omics and Symptom Science. And then Vanderbilt University has a genetics fellowship for family nurse practitioners. So we don't have a very uniform approach, but there are some really strong programs out there to address, again, this theory to practice gap. And many of us get our experiences, post-graduation in many of these funded opportunities. In my introduction, we mentioned an R25 that I recently received, but it was really quite an important milestone for both Dr. Lori Connors and myself to both receive R25s this past year. It's very nice for the National Human Genome Research Institute to recognize the important work of nurses and to also see the importance of preparing nurses in this era of genomics. So Dr. Connors is from Vanderbilt. She has an R25 and the acronym is TIGER. It's called Translation and Integration of Genomics is Essential for Doctoral Nursing. And it's a 5-year grant, and it's to increase the capacity and capability of doctoral nurses in the translation and integration of genomics. And then my grant is a little bit different in the fact that it does address graduate level nurses, doctoral level nursing faculty and students, but it is to improve the nurses' genetic literacy and genomic science literacy. Mine's set up in much of a way that, I want nurses without any genetic background to be able to think, oh, I can take this course and learn some basics about genetics and increase my own literacy, and also be encouraged to take a next step in their genomic journey. And then we also want to focus on the underrepresented minorities, because many times in genetics and genomics and in research, we have many minority groups that aren't represented. And so, one of my goals was to bring that to the attention of many nurses, and hopefully their work will start to involve underrepresented minorities. So that's a little bit about the basics of education with genetic and genomic nursing, but there are quite a few professional organizations that offer continued education and recognition as a genetics and genomics nurse. So the Nurse Portfolio Credentialing Commission offers certification as a clinical genomic nurse or as an advanced clinical genomics nurse. And these particular nurses provide services to patients with or at risk for inherited disease. And many of them work in specialty areas such as oncology, cardiology, neurology, pediatrics. And I think even in one of the very first noontime presentations, there was some talk about the genetic services at WVU and the nurses there, and how they actually take the I think it's the HOPE course, the oncology course for genetics. And but these are the nurses that I'm talking about. They specialize in certain areas that really focus on genetic conditions, and they're able to be credentialed. One thing that the NPCC is also working on is a credential for genetics nurse educators, and I'm very excited to see that coming in the future. The other organization is one that I'm most familiar with, and I've been with ISONG for many years. And this organization was started in 1988, and we have around 350 plus members, and from all over the world. And I've listed quite a few of the countries where our members reside. And this organization is really to support nurses from any field who are interested in genetic and genomic education, leadership opportunities, research opportunities, or maybe just want to learn more about genetics for their clinical practice. And every year we have an ISONG Congress, and the past 2 years, of course, we've had it online. But it is just a great opportunity for us to connect and provide educational webinars and research and clinical opportunities to our members. And then the Omics Nursing Science and Education Network, ONSEN for short. And I put a little video here that if you want to go to that on your own, it's just a YouTube video that talks a little bit more about this really wonderful resource. It is a group of nurses who were interested in omics in their program, and they created this resource network. And it's open again to all healthcare providers, but it is, it originated with this nurse science community. And it was to enable collaboration and mentoring and access to training opportunities across institutions. So they do provide resources for training, common data element support, and exploring partnerships in research. And some of you may be familiar with the Human Genome Institute, which is the Society of Coordinating Committee for Practitioner Education in Genomics. That's quite a mouthful, but this is an interdisciplinary group that includes over about 200 members from different professional organizations and societies and the NIH. And since its inception, it provides a forum for discussion and in-person meetings to develop resources for genomics education and webinars. And mainly the goal is to improve the genomic literacy of healthcare providers from many different disciplines. And it's it's a very, very exciting group, and it does a lot of good work. And again, I put a little YouTube video there for your own future reference. And then the very last organization, which is an international one, this is called G2NA. It was established in 2017. And what it wanted to do was just promote genomics healthcare and make it, again, very accessible to any nurse, internationally. And its mission is to support nurses to realize their full potential through integrating genomics across nursing practice to improve healthcare for all. And this is another really good website that provides webinars, publications, and a list of other genomic nursing societies that worldwide that nurses can become involved with. So before going into part 2, I just was wondering, is there any comments or questions about the first half of my presentation that anyone might like to share? I will will move on to part 2 of the.
Sorry, can you hear me?
Now we can.
Okay, my name's Amy Dameron. I work with GeneDx, and we have a team of about 30 nurses who do clinical records abstraction for us. So this is this kind of piques my interest. Are you able to send out some additional information on the courses that you mentioned, the online courses that will be available?
Oh, yeah.
Okay, great. Thank you.
I can talk to Kim. I can send, or Anusha could send it out. But I'll give the links to both of those and that can be sent out. Okay.
Okay, thank you so much.
Sure. So this intersection of disability and genetics, I'm hoping that this kind of brings it home, right? The whole purpose of, I think, Kim's grant and here is to think about Appalachia and the specific needs of the people in that area and the service that's needed there, and to bring some attention and maybe even talk about some ways to address some issues and barriers there. So I think there's this really important alignment between disability and genetics. You know, I say disability affects all age groups, cultures, and ethnicities. And so does genetics, right? I mean, we can drill down to more specific types of conditions, but overall, genetics affects all age groups, cultures, and ethnicities. And whether it's a single gene, a chromosomal disorder, or complex disorder, essentially every genomic disorder can be a primary disability, or it has the potential to result in some form of disability. So I think there's these great parallels between these two health conditions, right? And for those that may, I'm just going to, again, tip of the iceberg here, over 1 billion people worldwide live with a disability. So that's about 15% of the world's population. And it truly is the largest minority group in the world. And yet they're 3 times more likely to be denied health care, 4 times more likely if to access health care, but be treated poorly. And just to give an example, worldwide, there's about 75 million people that need a wheelchair, but only 5 to 15% have access to one. And disability is on the rise. And if I was in a classroom, I'd say to you, what are some reasons why you think it's on the rise? But, in the essence of time, one of the reasons, I'll give you a few, we have an aging population. So in some ways it's inevitable. The longer you live, the more likely you are to probably have either an acute or chronic disability. People are living longer with chronic diseases, which tend to have lend itself to disabilities. We have more survivors of violence and trauma, and we also have higher survivors of prematurity, all because, we have better treatments. I keep knocking this off. We have better treatments, and so survivorship lasts. We have higher rates of survivorship, but disability also comes with those higher rates at times. The one thing I really want to pull out, and again, I want you to be thinking also about Appalachia here, right? People with disabilities on the whole experience higher rates of poverty. 32% of people with disability compared to 11% of people without disability live in poverty. There are lower rates of employment rates. 14% of people with disabilities are employed compared to 76% of those without disabilities. They receive less education. I think only about 20%, in 2016, this is a statistic from there, 20% of people with disabilities had less than a high school education. They have unequal access to healthcare services. Women with disabilities have lower rates of mammograms and pap tests. Even getting on a scale to be weighed is almost non-existent at times. And adults with disabilities, there's higher rates of health risk behaviors, right? There's higher smoking rates, higher obesity rates. We have higher rates of diabetes and cardiovascular disease in people with disabilities. So you can see how this kind of creates the perfect storm. There's a greater risk of exposure to violence. And, when I read the statistics on this, I'm just like blown away. People with disabilities are 3 times more likely to experience violent victimization. Those are things like rape, robbery, and assault. And as a child, they're 1.5 times more likely to be abused. And then there's this higher risk of unintentional injury. One other thing that's not on this slide that I think is really important is to think about, there's a lack of emergency planning, which is a major safety issue. I'm sorry. For example, there were about 38% of people who were not evacuated during Hurricane Katrina because either they had a mobility disability or were caring for someone with that disability. And then I think it's really important if you think about how this perfect storm happens. If you're a minority from a racial or an ethnic background, plus have a disability, you have this health disparity amplifying phenomena. But I want you to keep this in mind as we talk about Appalachia region, because I too think that there's this amplifying phenomenon that we need to pay attention to. So the disability belt is this geographic distribution of people on disability in rural areas of Appalachia, the Deep South, and along the Arkansas-Missouri border. And it covers much of this Appalachia region. So I'll just show you this map here. So according to the Appalachia Regional Commission, there's a percentage of people receiving disability benefits in this area that's higher than the national. So about in these darker areas, that's the highest levels of disability. Overall, that area in Appalachia is about 7.3% higher than the United States, and where there's about 5% of people on disability benefits. But there's these 5 Appalachian subregions that report higher percentages. And like I said, those are those really dark blue areas. And Central Appalachia has a particularly high figure. It's about 13.9%. And then there's other more distressed areas around 13.6%, right? So I just really want you to pay attention to these darker areas and where you see these darker areas of people who, where there's higher rates of people on disability benefits, okay? So if we move to the next slide, again, there's same areas where there's these higher rates of cancer. And just real quickly, when there was a survey done in 89 to 95, the cancer mortality rate in Appalachia was only 1% higher than the rest of the US. But the time this map came around in 20,000, this was done in between 2008 and 2014, cancer mortality rates rose to be 10% higher than the rest of the US. It's a gigantic jump, right? From 1% higher to 10% higher. Again, this looks almost like the exact same map, doesn't it? If I go back. But now we're talking about heart disease. Again, in 1989 to 1995, heart disease mortality rate in Appalachia was 10% higher than the rate in the United States overall. But by time 2008 to 2014 rolled around, the rate was 17% higher than the national rate. So there's this growing disparity. And then diabetes, you kind of start to see a little bit lighter areas, but again, you've got this dark concentration in some of these areas. And then, and I just want to say that in all 5 subregions in Appalachia, they report higher diabetes prevalence than the national figure. The central area right here of Appalachia has a 13.5%, and North Central has a 12.8% report. And I think overall the US has a 9.8%. And then just looking at the lifespan approach, you know, down here in the southern region, we have some really darker areas, but again, some smattering here, you know, West Virginia, Central and North Central. The Appalachian region, it says here with a rate of 7.1 infant deaths per 1,000 births, the infant mortality rate is 16% higher in the Appalachian region. It's really kind of mind-boggling, isn't it? And to support some of this data, there was this really interesting research study done by McDaniels and colleagues in 2019. And it looked at this description of the causes and the rates of childhood epidemiology, childhood disability in the Mississippi Delta and the Appalachian regions. And, they talk about using the data from the US Census. And they looked at disability rates across all types, any type, ambulatory, self-care, hairy vision, and cognitive. And these rates were all higher in this Mississippi Delta and Appalachian regions. And, most rural and socioeconomically disadvantaged areas were within the Mississippi Delta that had the highest rates in the United States. So some things to think about, what this may be due to. These authors propose that, there's certain parental lifestyle behaviors like alcohol consumption and smoking during pregnancy may contribute to this. Lack of access to healthcare services leading to prenatal infections and low birth weight. And then exposure to environmental toxins may all contribute to these higher rates. And I just, again, want to point out that when you think about this health disparity and these amplifying effects, you add poverty into this mix of disability and high disease rates. We're seeing that, this area also has higher rates of poverty. In 2018, the number of Appalachian residents living below the poverty line was higher than the national average in every age group except over 65. And those with the largest disparity was among 18 to 24-year-olds. And they were 3 times higher in poverty than the rest of the United States. And then, not to overwhelm you with more statistics, but then you think about these health risk behaviors that, again, go into this amplifying phenomena. You have this level of physical inactivity, smoking prevalence, and obesity prevalence. And you can see, in the worst quartiles that, 43%, these are counties now, 43% of the counties have report these high physical inactivity rates. 189 counties, 45% of the, 420 counties in the region report smoking prevalence. And again, the obesity prevalence is very high in 126 of the 420 counties in the region. So I think it was interesting to think about, the genetics of all of this, and what are the residents of this rural Appalachian area think about genetics research. And again, this study by Fullenkamp done in 2012, looked at genetic literacy, genetic understanding, and residents in this area. And I thought it was interesting that they asked participants about their perception of genetic research and environmental health. And what I think was one of the really key takeaway messages, maybe not so much the individual items here, but with each one of those, the majority of people agreed with some of these phrases, right? But what was interesting was the difference, I think, between I need to know more or disagree. There wasn't this dichotomous, like I agree, don't agree. It really pulled out that there's some genetic information lacking among individuals in this area. There was a lot of response here about I need to know more. And maybe some of the highest responses, if we look at it a little bit more closely, were with about cigarette smoking and also environmental exposures. So, it shows to me that this, and again, the authors very much say the same thing, that the interaction between environmental exposures and genetics as a disease catalyst warrants further environmental genetic research, but it also warrants further education. This really stands out to me how important it is for us as healthcare providers to identify areas that people want more information about and maybe need to have, their literacy in those areas be improved and have access to some education around that. So, we can lay all this out, and I think it was really enlightening for me to even prepare this talk and learn a lot. But then I always think to myself, what next? I can look at all this data, I can look at all these things, and I'm one person. So, how can this change? I love these noontime talks because I think it's just increased awareness and has motivated us to think about these things more. But I really think that it takes some thought about adapting a certain framework with individuals and communities where we can have multiple entry points to make a change or make a difference. So just bear with me here. I know we're probably we're a quarter till, and this will probably take another 5 minutes or so. But I'm just going to kind of give you a framework and take this framework and walk it from the individual to the community and think about, what we can do as next steps or as nurses. So I don't know if anybody's familiar with this framework. It's called the International Classification of Functioning Disability and Health. But I was a trainee in a LEND program, a leadership education and neurodevelopmental disabilities back in my master's program. And I was really kind of trained many years ago in this classification system, and it just spoke to me. And I always think about this when I'm thinking broadly. So this ICF, for short, it's a descriptive way of capturing health and health-related states. It's always focused on health rather than the disease, the condition, or the disorder. It's not a medical model. It's like a social, social biological model. And it's part of the World Health Organization whole system of international classifications like the ICD-9s and 10s and things like that. But what I love about this is that all this interaction. So you could take a health condition and you can think about how it, affects a body function or structure. You can think about the activities of daily living that this health condition might impact. And you can think about how that health condition might impact participation. And I really like that there's a difference between an activity and participation. You might have an individual who, can use utensils and feed themselves, but does that translate to participating in an evening out with friends at a restaurant? That's participation. And then you have to think about these contextual factors like personal factors and environmental factors. And then there's all of this interaction, right? So again, bear with me here. There was this sample about a health condition like breast cancer, and I just picked this one because, you know, it can have a genetic component to it. But you can see that the health condition was breast cancer, post-mastectomy. They give you a list of body structures and functions here that were affected. And this gives you a list of activities here of daily living. This gives you an insight into this person's ability to participate in employment and fitness. And it also gives you some environmental factors. This person happens to have a supportive family structure and a work environment and good health insurance. And they seem highly motivated and have financial stability and a strong self-advocate. But that could be very different, right? And I've had individuals that I've worked with that have very different personal and environmental factors. But what I like about this, let's just say that this person, you know, wasn't highly motivated, or maybe needed, you know, didn't have support at work, or needed some help with finding an exercise that they are able to do. I mean, each one of these boxes, there's a way for us to intervene. And you're not like tackling everything all at once, but you're working with the individual, and you're, you know, there are just these different openings that can make a difference, a small difference. And if I make a small difference here, it may impact her participation or her ability to do activities. If I make a small personal change here, it could change all of these other boxes as well. So when I think about this, and I just think about this when we think about a community, and it may be one of those, you know, areas of Appalachia, it might be one of those smaller communities. You know, can we look at that community and think about the health condition of that community? Can we think about the structures and functions, which I would think are the schools, the medical facilities, the businesses? Are they present, not present, right? Can we look at the activity levels of the people who are in that community? Whether the, you know, number of sick days, mixed days of work, what is school attendance like? And then do those activities, you know, translate to participation in that community? What are the employment rates, the graduation rates? Is there opportunities for people to engage in sports or park usage? And then you can think about the environmental factors, many of which we talked about already. What are the poverty levels or the rates of genetic conditions, disability rates, the economy, accessible transportation, and then the personal factors. You know, the one article was talking about the literacy of those in the environment. Is there safety? Is there resiliency in the community? What are the neighborhoods like? And although this is, you know, about genetics and genomics and disability, you know, I think it captures all of those health conditions. But if we, you know, if we go into a certain area, can we make a difference in any one of these blocks that will eventually improve the health condition of the community? And I just think that it's possible. I think as we see these statistics, and these statistics may not be very inspiring and they may be sort of depressing, I think that we have to think about a way to make a difference. And for me, this is one way to conceptualize that. So that was the end of my discussion or my presentation. So I'm happy to think about ideas or reactions or anything helpful that I can be.
Well, thank you so much for a wonderful talk. And I'm, you know, have a lot of ideas going through my mind, but I'll go ahead and kick us off here with a question. You know, you talked about a lot of issues that were problematic in Appalachia. What would you say is the primary challenge for genetic services in rural Appalachia?
You know, two things come to mind, right? I think accessibility to services, right? And genetic literacy. I think genetic literacy is huge. You know, health literacy, genetic literacy, however, wherever you want to begin with that. Just being able to, you know, giving people an opportunity to be able to say, yeah, I'm interested in this, but I don't understand it, you know, or how many times do, you know, we were talking earlier about Fragile X, and the phenotype of Fragile X for both males and females has changed a bit, right? So how do you explain that to someone who's saying, you know, I have a daughter who just can't seem to understand something, or I have a mother-in-law who has tremors and her cognition's, you know, reducing, and just to be able to think, oh, this could have a genetic component, and that doesn't have to be scary, is I think a really big obstacle, whether it's in Appalachia or just across the board, right?
So as we think about a research agenda, what do you see as some of the opportunities for research to improve genetic service delivery in West Virginia and our region?
Yeah, I think just, you know, those two studies that I just brought up, I think it's really interesting to, you know, delve even further into this environmental genetic interaction. I think that that would be really important. And also, you know, again, from my own perspective, I think just understanding the impact that genetics has on everyday functioning for people. And then, you know, just really, and again, interventions that can be improve the health care of individuals.
Great, thank you. Anyone else have questions that they would like to ask? I had a Brazilian roommate, and one of the expressions that they had was turn out the light and whoever wants it will take the piece of cake, you know?
That's funny, yeah. Well, I just hope, you know, I'm just hopefully, you know, just provided some food for thought, you know? There's
so
something.
It looks like we have in our in our chat there.
I think that's a great question. You know, what types of community-based interventions can nurses participate in that make a difference in a wide scale basis? You know, I really think, you know, the community efforts that we make on any level, you know, I mean, I lots of things start popping into my head, but just, I think having a presence, you know, in a community is really important. And as in any community, I think that takes some time to build trust. And I also think one of the most important things with community-based interventions is to have this engagement with the community so that we're understanding what their needs are, right? And that it's, you know, it sounds rather simple, but it's got to be the community's agenda that we're addressing and not our own agenda. I mean, we see these statistics, we see all these needs, but, you know, I remember and this is minor, but I remember starting the Fragile X clinic. And one of the first things we did was we had a forum with some families who were part of the clinic. And we said to them, tell us what your needs are. And I was shocked because my needs about the clinic were very different than their needs. And one of the very first things they said to us was, we need a dentist referral, you know, we need who can understand our children and their anxieties and have the patience as well as the competency to care for them. And, you know, finding them a dentist was not my top priority, but the fact that they said that to us, and then we went and researched, you know, and had good referrals for dentists, that helped build trust with those families. And it really made a difference in their support of the clinic and trusting us on other things. So, you know, those community-based interventions, I think the most important thing is to be present and to really understand from the community what the needs are. And again, it may not be our top priority, but we'll get there, right? I hope that helped.
And I think that's so true about the rural Appalachian population in particular, because there is some, I guess, concern that they may be seen in a bad light, or, you know, people have prejudices against people from Appalachia. And I think getting buy-in to really help people open up is so important.
Thank you. I'm glad. Other
questions or thoughts?
I have more of a comment than a question, but I'm a genetic counseling assistant. I actually work with Amy at GeneDx. And I grew up in Kentucky, which is a very largely rural state. I don't know if we have any other Kentuckians on the call, but I have very limited experience with nursing specifically, as opposed to, you know, working with nurses. So it's great to hear about all the advancements that are being made within nursing, considering genetics specifically. I used to work in a low-cost free clinic in rural Kentucky, and a lot of people would come to that clinic even if they had insurance, just because they were so familiar with the nurses that worked there. We didn't have an MD, we just had nurses that were fantastic, and I think it's great to see that that is being focused on within nursing, as opposed to just trying to, you know, shoehorn in genetic counselors and MDs.
Well, thank you so much. I'm glad that that was helpful.
All right, so we're coming to the end of our time, and I would like to take this opportunity to thank Dr. Kronk for a wonderful presentation. And I'm sure we all have ideas that we're thinking about, and ways to incorporate and work more with you know, genetic services and nursing services. And we appreciate the efforts from Dr. Kronk and folks like her who are really going into communities and identifying needs, especially in our Appalachian community. And so Anusha has posted an evaluation survey in the chat, and we would be most appreciative if you would go in and give us feedback about this session. And we also have other sessions that we would appreciate your feedback about. So thank you so much. And next month, we'll look forward to a conversation with Dr. Graves, who is doing some work, research work with the medically underserved population and genetic services. So thank you again. Thank you, Dr. Kronk, and thank you all for joining us.
Thank you.
Bye-bye.
Bye.